close Treasury, Minister of Treasury, Minister of Health, on how we're going to fund the project. So everything is actually almost ready and done. So we're not going to replace that. At the moment, we'll use it, we'll repurpose it after COVID to suit what we actually want. I wanted us to be clear on, and I think the issue of procurement will have to fast track it, because they are now means that we've put into place to fast track the procurement and get some of the items that are lead items. Yesterday we got an indication that we are going to get a first stock of remdesivir into the country, which I briefed you from the NUMSA guys. So we might also be having an added way of how we're going to treat our patients. So a lot of progress is made. We are very anxious. I don't think a normal person who's within this period will not be anxious. We are anxious. We just have to, now we are not planning anymore. We are responding on our daily challenges, all our shortages on a daily basis, like we normally do on a winter. It's just now it's a winter with COVID. So when we have shortages, we'll have to respond quickly. The only important issue is to respond as quickly as possible. Those are from Eastern Cape. We have to now roll with the punches. There's no way to say we can stop the punches. They are here. So I within the storm. And thank you, Minister, for making time just to also be with us and know where we are. But it's a lot of work that has been done, and there's still a lot that can still be done. From when we started to where we are, it's a whole lot of improvement that has happened. And thank you.
Thank you very much. No, let me just make a few comments. We didn't come for a long meeting. We just came for a briefing. And thank you very much, Dr. Libet, the CEO, for the briefing that you have done. What you have told us is actually adequate for purposes of why we were here. It was, of course, important just to also acknowledge the unfortunate case of the child who was brought in here, and then there was a report of the child having been abused. We take a very strong stand against abuse, against negligence, against mismanagement of patients. We take a very strong stand on that. And certainly if we get a complaint of that nature, which is very serious, we do support that an immediate steps must be done to investigate the matter and make sure that justice is done and that the law takes its course. And therefore, I was pleased to hear that you had moved the way you have. Obviously, the matter is under investigation. I wouldn't like you to go further than what you have just said. And it's important for us to say we leave it into the hands of the law to take the matter forward. So thank you very much for that. But secondly, you have given us a very good sense of what is happening here. If I take you back a little bit, the COVID, the fight against COVID has been a very interesting thing in the sense that there was no textbook, there's no blueprint. You have to respond to the disease as it manifests itself. And in this case, we initially started by designating a few hospitals, and we didn't count all of the hospitals. We took a few, and a few weeks after that had happened, I said with my colleagues, and I said, we are going to run into a bigger problem. The manifestation of the pandemic is such that it's going to be showing up in every part of the country, and therefore let's go through a screening to see where the heaviest infections are, and therefore prepare those areas first, but then everyone else needs to be ready, and therefore we came up with a differentiated strategy that said there must be areas of hotspots where we put a lot of additional work, prepare our facilities even further, and also make sure that we've got teams in sub-districts that look after smaller areas of the clusters of wards. And that is the point at which we then made sure that every hospital must begin to create triage tents so that every patient who walks in there must be separated. Those who have got suspicious symptoms for COVID-19 must therefore be moved aside so that there's no mixing of patients to avoid a situation where someone comes in with a different disease, but because of COVID, they infect people who have got other comorbidities and worsening the morbidity rate and the mortality rate. This was the experience in China, and therefore the separation, early separation of the patients as they're walking becomes very, very important. So our initial focus was that the Gauteng was going to be shooting up ahead of everyone. So when we put up the lockdown, we looked at the trends and were quite comfortable with the fact that a very strong tracking and tracing system had actually managed to sequestrate, isolate, quarantine and those who were affected and kept the numbers down, and actually brought us a period of about 3 months where things were not coming on very, very rapidly, as it were. But later on, we started having a challenge with the testing capacity with diagnostic kits, which were not flowing into the country as we were expecting them, and this was a problem throughout the whole world where we were experiencing. So we then shifted to focus on high priority areas, which is now where your patients who are admitted, your patients under investigation, your health workers immediately, as well as patients with comorbidities, so that we can limit the negative impact of the infection. Now, it became important now as we looked at the pattern of how the numbers were rising in Gauteng, then we realized that we are going to need beds faster than what we had planned, and therefore we then activated emergency intervention teams, and this is what the CEO was talking about. The emergency intervention team is a combination now of the national department and provincial department. They go into the area, they look at what is needed, they look at the pressure of numbers and how many beds are needed. And right now, when we feel that there's the hospital is under pressure, they must not waste time. They must actually go in, make the assessment, come back to management, take the decisions, come back, get the authorization. They can phone me, MEC, they can phone me immediately to say there's a blockage here, so we get to deal with that, open it up and move on. So what you've seen, movement within a few days to get beds opened up and so on, that's the pressure we're putting, because we can see we have an advantage. We still remain ahead of the curve. So the distribution of COVID is not going to be standard everywhere. So you're going to find areas where there's a rapid increase, which you didn't anticipate. All we must be able to do is to respond quickly, to go and make sure that we can provide what is needed in that area and move on. So I'm happy with Dr. Mlada, the approach that you are raising, because indeed what we do, we pick up complaints now from staff, from unions, from the clinicians and the local management, and we want the response time to be quicker. You shouldn't feel the frustration and then you are told we're waiting for the regional director, we're waiting for the district office, we're waiting for the provincial office. Things must happen pretty quickly. And I'm very happy that you've been able to find each other between management and labor, because that combination is a very important team to be able to deal with it, with issues. Half the stuff that the management wants to know, the unions already know, because it's easier to talk to the unions. You raise the issues there, but then there must be a free flow of information and an easy atmosphere for discussion. Sometimes it becomes tense, but that's not the problem. The real issue is that you confront real problems and solve them. There are laws of how you relate, and so everyone knows that if you are labor, this is how you work. If you are management, this is how you work. So the law allows us to be able to interact. Sometimes, of course, you find that the tensions will arise. But what has been important is to create these occupational health and safety committees, a platform where labor will pick up a concern from a member who is worried and come and raise it with management, and management goes and check and say, no, don't worry, we'll sort that out. And then the issue is closed. It is not necessary for labor to even ultimately go to protest and fight. That always indicates that there's a breakdown. Where there's no breakdown, people sit like this. You sit here, you argue, debate, and once you're done, you come with a solution and you solve the issues. So in this case, the protection of the staff is very important. Now, you see, protection of the staff is a concern of management. The protection of the staff is a concern of the labor movement. Protection of the staff is a concern of government and everyone out there. So it's something that we shouldn't be fighting about. We must just always go and check what's the problem and close the gaps. So I was very keen to get a sense on your PPEs, because what we found is that we've got quite adequate supplies of PPEs at this point. There was a shortage at some point, but the distribution sometimes is where the devil is, because from the point, from the warehouse to the hospital storeroom, and from the hospital storeroom to the ward, and from the ward to the individual, that chain needs to be tightened. If it's not tightened, it really creates a breakdown. Now, the majority of tension that comes from labor is anxiety of the staff who feel vulnerable. And I think we need to understand that it's not so much that people don't want to work. Their issue is if the soldier in the forefront is worried about confronting the adversaries, you can't win that battle. What you need is that they must be the ones who are confident to say, bring it on, we're going to deal with it. Like now what we are saying now as a director of the nursing management, that the key is to make sure that our staff, our nurses, our general workers, our clinicians, everybody must feel confident that they can sort this COVID thing, because they are well trained, they are well motivated, they're also well protected, and they've got all the equipment and the medication that they need to be able to confront. But there's nothing as frustrating as to face the patient. You know what to do, but you can't do it. And so that's why we're coming in to say, let's just check what is it that you can do to ease off the pressure so that you can just focus on the real fight. So as we sit here now, I think that what is important, which is what we've been working on the past few days with the MEC, and we're doing this with the rest of the provinces. If somebody picks up an issue and we pick it up on the ground, we then go onto it to say, what's happening here? Why is the problem here? So in your case, we have sent the team of the emergency intervention, and I said I wanted to see where they're working. I don't want to get the report, but the reports are nice. They're always well written. These days they're digital, so it comes in quickly. In the next 5 minutes, your report is there. Not the same as when you go and see. It's important, so we want to have a look at that. And certainly, where there is an area, we've also agreed that we're going to put on, marquees and alternative building technology to build wards that are going to create beds quickly. And therefore, we must be able to make sure that the numbers can escalate. So each time you think you're going to be having about 300, if somewhere in the next few days you look around and your projections give you an indication that you might actually need 400, we need to know now so that we can put the process into place. Because what is happening, we can see the surge is coming, and what you're seeing is actually the heavy drops that are here. But what we want to do is to make sure that we move always ahead. So by the time that surge comes, we've got enough beds, and where there was a miscalculation and maldistribution, it must be corrected ahead of the surge hitting us. So that's the main issue. So what has arisen in the past week or so has been the need not only to reticulate oxygen pipes into every bed, because filled beds are going to be more useful if they've got oxygen piping getting closer to all the patients. It seems to us, as has been now demonstrated, early oxygenation is going to be one of our major weapon in this case. So we then realized that whilst the process of fitting is going to take a few days, a few weeks, we won't wait for that. We're going to then put up the oxygen tanks and then congregate next to those tanks a number of patients so that you can always immediately put your patients onto high flow nasal oxygen, and then your patient can stabilize. And then what has caused the problem is the fact that if you've got fewer beds and therefore they are occupied by people under investigation, you then get a sense that your hospital is full even before they reach to the hospital beds, simply because you can't move them until you've got a clear understanding whether it's to go to a positive COVID site or a negative COVID site. So that's why we're putting pressure now to say, open up the capacity, then you must never feel you must turn this patient back. You must never feel that this patient is not being attended to. That's why we're here. We're moving around, therefore, trying to put all of those systems in place ahead of time. Fighting this pandemic is not like you sit here and make a plan and then things are going to roll. Every day we want to check what's happening every day, and we want you to be able to say, if you see something that needs attention now, let's talk now and let's see what can be done. So we're putting up these oxygen fittings, and poor MEC, his wife at the birthday, but on the weekend, but he had to start running to deal with the issues of NASREC, bringing out the oxygen concentration tanks, and then we had some of the doctors that even made calls to say, listen, anyone who wants to make a contribution, come on board, and so on. I said, no, that's fine. Those are initiatives that are fine, but we will move ahead as government and make sure. And in some of the instances, they even started calling, hey, volunteers, come and help us, and so on. Again, that's a good spirit to mobilize, but we actually have a whole program now to recruit additional staff. The province has gone into a database, collated it. They've got over 1,300 nurses that we're actually sourcing out of that, and that combines the database of unemployed, and we've also gone out to deal with the nursing recruiting agencies. So the batch of nurses that you received yesterday are coming from that crew. We actually distributed them through 4 hospitals. Yeah.
4 clusters.
4 clusters. Yeah. So that they are directly contracted by national department. We normally don't hire nurses for hospitals. This time around, we're doing everything to make sure that we close the gaps. So once the system kicks in and so on, those nurses will be absorbed in whatever form. Right now, we want them in place and in office. In some of the hospitals, we actually took them by surprise because they had a shortage, but they had not quite figured out where they're going to place them. So we phoned, no, we put them in the boardroom. We're going to quickly work out where to take them to. They didn't anticipate this rapid turn of events, the speed with which things are now being pushed. So I'm very pleased, therefore, that you will receive some of those nurses. And so basically all we want to say to you is that there's one team here, and that team is going to be working together. You, the MEC, the national office, everyone else is one team. So if there's an issue, let's just talk and try and see how we can speed it up and move ahead. It's important for our people to know that we're going to do everything to save their lives. It's important for our people to know that we'll do everything to save the lives of our health workers. It's important for everyone to know that we are determined to deal with the COVID-19, and in the process of dealing with it, there are going to be mistakes here, there are going to be shortfalls here, and so on. We don't worry about that. We simply pick it up and correct it. If it's a mistake, if it's a shortfall, we must pick it up and get it corrected and then move on. So the surge is expected that's going to be high in Gauteng province. And if you look at the numbers, the Eastern Cape is also rising, but in fact KwaZulu-Natal is beginning to have more numbers per day than Eastern Cape. Now that was the original projection. The Gauteng is going to be the highest surge, followed by KwaZulu-Natal, and then followed by Western Cape, and then in the Eastern Cape. Interesting the way that the trends are now panning out. If we're looking at the Western Cape, then they actually took over early and overtook everybody and were like the epicenter for almost 2 months. And as we are analyzing their trends, now I did say at some point that at some point every third patient who was COVID positive in the country was in the Western Cape. They are down now to about 40%. That meant not so much that they were not increasing in the Western Cape. It meant that the other provinces have now taken over. We did expect that that's what's going to happen because after the lockdown, community transmission has been going on slowly, but once we release the levels, then the numbers have begun to surge. And people in the community get infected, they infect each other, but when we said miners must go back, then the miners went back. The first few of the clusters that we found in the mining areas were actually people that come with it from the community. So that's what happened. Now, if you get the schools now which are having a higher level of infection, in those mining areas, it's the same areas where they're associated with a higher level of infection in the community, in the mine, and here. So most of the teachers and the children who are learners who are at school who are positive, the bulk of them didn't get infected from the school because the schools were closed. The infection went up in them as members of, as teachers, as learners in the community. So there is a level of infection that you can't stop. But nevertheless, a number of them are asymptomatic. The few that get to our situation are the ones that you are focusing on. And we're saying to you, want to come here and strengthen your hand so that whoever you see, as few as possible of them must be compromised, a few as possible of them must be lost, but many of them must walk out having been properly managed. I think therefore, and there's enough expertise with the doctors and the nurses, all our clinicians in charge. We have no problem that they know exactly what to do with this case. However, what is important is to make sure that we are there to give them the necessary backup so that they do their best in these situations. So we have ordered a number of ventilators, and those ventilators, they'll be coming in batches. And what has been most exciting for us is that CSIR is actually the one that's going to be providing. Now, the best for us is when a government, a parastatal, is actually the one that's producing this equipment, because the drive is more the service more than the profit issue. Although, of course, it's not a big issue because the technology is technology, as long as we can find it. But I think it's a very good indication to have CSIR being the one that's providing the ventilator. So over a period, we'll therefore be giving to everyone to get their bits of equipment. Remdesivir, we have had a discussion with the company, Gilead, that is producing that developed the drug, and they've partnered with about 5 companies worldwide, and then 2 of those companies are active in South Africa. They may not necessarily produce the drug in South Africa, but we've got their presence in here, so we hope that we'll be able to have access to that. But Dexamethasone, all of us know, we've always used it, and all the steroid lines, and of course the company that owns the rights is also South African. But again, we're going to look at how to maximize. At the moment, we've got adequate dosage, but the adequate supplies. But as we need to increase, we're going to be able to supply that. The good thing about dexamethasone and oxygen, high-flow nasal oxygen, is that you can put it in any district hospital, and any doctor can administer without any problem. And so that means, therefore, we've got an opportunity to make an impact, even at the lowest possible level, to deal with the early admissions. And therefore, we should really be, going on with all the courage that we should be able to make a lot of difference. Gauteng has had a much lower mortality rate than what has happened in the rest of the country, just over 600, but in the Western Cape we're about over 2,200. The numbers are now going to start picking up in Gauteng, and therefore what we are seeing means, slowly the numbers are shifting more towards Gauteng. The surge will be higher. That's why we're focusing on preventive measures. So when we decided to stop to suspend the sale and distribution of alcohol, it's because of the pressure on the trauma units. Your theaters, your ICU, your outpatients should not be clogged by people who are bleeding, so that all you can do, even if the person is COVID positive, you won't even think about it, you're just focusing because the person is bleeding, you must quickly deal with that. But right now, we think that's going to help us to stabilize the numbers. The introduction of the ban in the previous situation actually helped us to reduce the numbers. But 1 month within the time, 1 month after the opening up of the sale of alcohol, the numbers moved up 40–50%. Now we can't afford that. We need all the beds, and that's why we've gone the way that we've gone. So it's to balance the beds. At the end of the day, when we don't have pressure of beds and so on,